Okay, well, how about Meredith, then Jesse, then Jessica? That's the order for me anyway. Just maybe mention where you're from. Let's see.
Meredith, you're on mute.
She's not on mute, but we can't hear her.
She got her camera working, but we can't hear her.
Okay, well, she can work on that. But yeah, Meredith, thanks for joining from Homer, South Peninsula. Then Jesse, and then Jessica.
Sure. I'm Jessie Downs. I'm the nurse consultant in the section of chronic disease prevention and health promotion with the state of Alaska.
Great, thanks, Jessie. And she's going to talk a little bit from 12 to 12:30, so I hope you can all stay on for that. Jessica, great.
Hi, I'm Jessica Pugh. I'm the Policy and Procedure Manager at YKHC out in Bethel.
Great, and Deborah as well.
Hi, everyone. I'm Deborah Sampson. I work in the Performance Improvement Department with Jessica.
Great, thanks, Deborah. I'm glad you could join. And the Flex team, I see them next on my list, Kate and Erin.
Hey, I am Kate Harmon. I'm with the state of Alaska and part of the Flex team in Anchorage.
Hi, Erin with Mount Pacific, also part of the Flex team, also located in Alaska.
Great. And then Chris, and then the Manila team after Chris.
Looking for my mute button. They gave me a new screen and it doesn't have a camera. So I'm gonna turn and talk on my little camera. I'm Chris. I work in process improvement, quality, and patient safety here in Fairbanks at Foundation of Hope Partners. And yeah,
Great.
that's me. Good
Glad
morning.
to be on, Chris. I see two from the Manila team so far.
Hi, good morning. This is Monica. I work in the quality department here in Manila with Helen. Helen will be joining us here in a few minutes. She's in a different meeting.
Okay, great. Thanks, Monica.
And I'm Heather. I'm the inpatient case manager here at Manila Health Center.
Great, glad you could be on, Heather. And then I know Lindley's in her car, so I don't know.
Lindley's from Valdez and she's driving somewhere.
Yeah, so we won't make her introduce herself. And oh, great, we have Jeanette. You're able to make it.
Hi, everybody. I'm Jeanette Lacey. I'm the Director of Case Management at Bartlett Hospital in Juneau.
Great, thanks, Jeanette. And I know Debbie said she might pop on later. She had an appointment. And then I think the last person I haven't introduced, Dina. Great. Oh, you're on mute.
It didn't unclick. Sorry about that. Dina
No worries.
from Bristol Bay Area. Oh, I cannot talk now. BHC out of Dillingham. Nice to meet you guys.
Great, glad to see you. I think, did I miss anyone? Great. So, and I didn't introduce yet Megan, because you're going to be talking. So I'm so glad to have you here and all your work on social drivers of health. So she has some slides she's going to share and do a quick little presentation for us. You want to share those, Megan?
Yes, thanks, Debbie. Let me see if I can get it to share the way I want it to.
Great. And feel free to stay on video or go off video during this, whatever feels most comfortable to you guys.
Okay. Can you see my screen?
Yes.
Okay.
Oh, we're seeing the next slide. It doesn't necessarily matter, but
oh, okay. Let me try one more time. Sorry.
No worries.
You're showing the presentation mode.
Try this one.
It's funny because we did it right before. There we go. Perfect.
Okay. Thank you. Okay. So hi, I'm Megan McKiernan with Norton Sound Health Corporation. I'm the Chief Quality Officer. And I was asked to talk a little bit about our Social Determinants of Health project. We worked with ANTHC and a couple of the other tribal health organizations and selected to use the Prepare screener. Prepare was created by the National Association of Community Health Centers as a validated social determinants of health screener. It is a free screener. That was one of our big reasons we chose it, and it is already available in a whole lot of languages for free. And they already had a Native American version that was a little bit more culturally relevant than the regular version. The standard prepare screener is 21 questions. Again, it is free, which is not the same with some of the other ones. It can't be modified without approval. Sorry, cannot be modified without approval, but they have already built the integration for many EHRs out there. So, and that was another reason to choose prepare, because the integration was already built, and basically we just had to have Cerner turn it on in the background, which was very inexpensive. What was a little more time consuming and a little bit costly was that we modified prepare to be more relevant for our community. And you can see there the elements that are in the standard prepare screener. We did modify it. So we looked at the questions and wanted them to be more relevant for Alaska and specifically our populations. The questions needed to be culturally appropriate and sensitive. And we added 2 sections, one related to community and one that we did call cultural connections. And then we rearranged some of the questions. We then submitted it back to NACHIC and the prepare group to get our revision approved, and it was. Our added questions don't count in the scoring, which is how we got it approved. But they otherwise did approve that our modifications. So the challenges we had in our modifications were making sure our questions applied to all. So Norton Sound originally wrote the added questions, and then we worked with Manilik and Search and Kodiak Area Native Association and ANTHC to modify the questions so that they're not just for Inupiat or Yupik people, but really do apply no matter what cultural tradition someone's coming from. And we wanted to get this information to help understand our differences. We were looking for, what information did we want, what was important to us, and then what were our goals, what were we going to do with that data. Our motivation for really adding these cultural questions is a lot of social determinants of health really focus on the negative. What are all your problems? And we wanted to also focus on the resiliency factors. What are the good things going on in your life, or the things that can go better in your life that kind of act as negative points, help address some of those social determinants of health. So that's why we chose to do this. And you'll see some of the questions we have there. It was important to our team, for example, to separate out different types of hunting and harvesting. So we have mammals and birds, and separate from seafood. That was important to us. So our initial rollout, because it was going to take a long time to get it in Cerner, we didn't want to wait. So we elected to roll out using a secure Microsoft form that the patient can complete on an iPad. And we did it at community events. We did it through our behavioral health department. Anywhere anybody could take one of these screeners. And we went around with stacks of iPads to basketball games, talking circles, tribal meetings, and worked with people to complete these surveys. By giving them the iPad, it does let them know here that the Responses will be given to their care team and are part of their medical record. So we want people to be aware of that. Then we collaborated with ANTHC on building it out in Cerner. This is what the ad hoc form looks like. So there's not a way in Cerner for patients to complete it on an iPad. A staff member has to go over the survey with the person. So we still actually use the form, Microsoft form, quite a bit. Have people fill it out on there, and then we transfer the information into Cerner. And you can see here what the form looks like. It does automatically score for the patient, for the staff down in the bottom corner, so they have an idea if that patient has a high risk score. And we use the prepare scoring strategy, and some great coders and builders at ANTHC who know how to make that whole scoring thing work. So I took some on a demo patient this morning. If you fill out the survey, then based on a person's responses to the question, they'll get that risk tally score. If their score is over 1, it identifies that there are some risks that for that individual. Those risks automatically populate in the person's diagnosis and problems list in Cerner, as patient stated. So based on the patient's responses, identifying these issues for the patient, those do jump across using the codes, and that's that build that's already kind of there between Cerner and Prepare. And if these are not correct, or after talking with the patient, they can be resolved and removed. But oftentimes we find patients are really honest on this screener, and that it identifies things that providers weren't necessarily aware of. We also have a standard that you don't do a screener for something like this unless you have a response for the patient. So if the patient's going to disclose and be vulnerable and let us know that they have needs, we need to be ready to step in and address some of those needs. So we developed resource pamphlets for every section on the screener. So there's one for resources, there's one for housing, there's one for safety, there's one for cultural connections that provide phone numbers, contact information for resources throughout our region, specifically related to each of those areas. And then whenever we're giving those screeners at a community event or whatever, if the patient identifies they have needs in a particular area, at a minimum, we're providing them these handouts with links to resources for those items. And then I wanted to provide briefly, what sort of information are we getting? So this is from our Microsoft form. We do have some dummy patients. We let anybody who wants to can go into our form. Feel free to take it, take a look at it, play around with it. So that does throw off our numbers a little bit, but in Microsoft Forms, it does automatically make some nice graphs and tabulations for us. You will see, so some of the things we identified here, patients who have challenges. So we identified that like utilities is a big challenge for folks, maybe more so than other areas. We looked at our traditional practices, and we found while most people say they feel connected to their cultural practices, when we looked at what that actually looks like, for most people, that is gathering, that's picking berries, that's fishing, and much lower participation in things like dancing. So that was good information for us for targeting our resources. We looked at percentage of people who are really having stress, feeling a lot of stress, or feeling lonely. And loneliness is something that we identified more of than we expected to in communities that tend to be very houses tend to be overcrowded and things like that. One example, I had a provider call me and say, hey, this diagnosis popped up in this patient's chart, says that she's lonely. And I said, well, that's based on what she said on her survey. And the provider said, yeah, but she lives in a house with like 8 people. And I said, that's okay. It's possible to be lonely in a crowded place. And the question's really getting about how often are you seeing and talking to people that you feel close to. So having that meaningful conversation. And that was something we identified and we're able to help that patient with. And I'm going to just skip back. If you're interested in taking a look at our form, here's the link. Feel free, like I said, to go in there. If you're going to do a test patient, when it asks for your MRN, just put 0, and we go in and delete those on a regular basis, because we use them for training and everything else.
I can put that in a minute in the chat too. I think I have that link because I looked through it too. So
yeah.
Wonderful. Okay. Thank you for sharing, Megan.
Thank you.
Is there anyone has any questions for Megan? Or comments or?
Thanks, Natalie.
Yeah, Megan shared this with Kristen and me on a call recently. I was like, oh, you got to share this with the group because this is awesome. You guys have been doing that for about a year now, right?
Year and a half, yeah. And thanks to the other organizations who helped us with getting that live in Cerner. A number of folks here at Norton Sound who participated in that build. So thanks to, it definitely wasn't just me.
This is Jeanette. I have a a comment. I mean, this looks great work. I don't know if anybody knows if Prepare has built it for Meditech, but we built it ourselves. But if I'll have to see if they've done it for Meditech, because I love how it automatically goes to the problem list with the code. So my question was, who on your team is entering it? So you're doing a Microsoft document, giving that to the patient for them to fill in, and then your staff are entering it, is what I understood. So who's doing that?
I have some interns who I challenge with doing that. Basically, anyone on my team who has spare time. Whenever they have downtime, if you have 5 minutes, you can get 1 or 2 done, because they're pretty much multiple choice. It doesn't take very long to put them in. And so on my quality team, I have a number of people. They're all variants of part-time. And it's like, hey, if you've got 5 minutes, if you're sitting in a webinar and this is something you can do while you're doing that, our goal is to stay caught up. Sometimes after a big event where a bunch of them get put in, it may take us a week or so to catch up, but usually we stay pretty on it.
Because you would have to get those entered before they discharge to get the codes added to the final.
Correct. And because most of them are getting put, most of our surveys still are getting done at community events and not during encounters. So they end up being there the next time the patient has an encounter. But if you're doing it in a community event or during an encounter, you'd probably want to put it straight into Cerner, or you're going to have somebody, definitely doing it in the same 24-hour period.
Well, wouldn't you have to redo it for each hospital visit so that it could get coded to that visit? I mean, I know the information doesn't change, but I mean, it does change, but it doesn't always change a lot, and it doesn't always change fast. So I think you'd have to add those codes.
Right, I think you would, I mean, for us, I believe they're dropping onto the problem list, so those codes are gonna stick around. Unless you resolve them, but it is a good idea. Our goal is to get where we're screening, almost every visit, because it does, certain items in there will change, certainly. It includes the safety screener, like domestic violence screener and things like that. We've kind of stuck within our screener, the prepare. And we rearranged the layout a little bit to put the most controversial questions at the end to try and get people to answer as many as possible before they quit. But I think however you're going to set up your workflow, but I know for us, to count for that visit, it would need to be in before the end of that, before midnight, the night of the encounter.
Well, before discharge.
Correct. So for our outpatient encounters, end at midnight. For inpatient encounters, yeah, it'd be before discharge.
Well, great work. This looks wonderful.
And if you go on the Prepare website, just Google Prepare, they have a guide that you can download that has all of the like implementation resources, and listed in there are all the EHRs they've built out for.
Great, thanks. And thanks, Megan. And we're trying, that resource guide that you've put together, Megan, like for each question, we're trying to make a template. We're working on a template that we can share with every community based on kind of what you've done. And so we'll be sharing that with everyone at probably the next meeting. So anyway, thank you so much, Megan. And Natalie, I know, has a lot to talk to us about, so I'm going to let her take it away from here.
Thanks, Debbie.
Thanks.
Yeah, thank you, Megan. That was excellent. You have teed up what I'm going to talk about in theory, and you showed the reality of it really beautifully. So thank you so much for sharing. What I wanted to talk about today with the group was starting to think about, now that we've talked a lot about getting set up and starting to collect data through the screening process. What I wanted to talk about today was ideas for how to actually use that data and turn it into information that you can use both with individual patients, and then looking at the information in aggregate as Megan showed, to identify patterns or help you understand new things about your community and the patients that you serve. And so this is just a kind of a framework to illustrate the question I wanted to explore with the group today. And that's how can this data help us move from addressing those individual needs, which we've talked a lot about, right? The power of focusing on one patient at a time. How do you take the information that an individual patient is sharing with you at an encounter and meet those needs in the moment or over the long term? How can we also then think about, as we collect this data over time, we're going to have a pretty rich set of information data source. And so how can we then use all of that to help us think differently about the policies or programs or partnerships that we have to start to address some of these underlying social drivers of health in our communities? So let's start with the individual piece, because sometimes I think this gets glossed over in the implementation. And I've heard stories from organizations and would love to hear what your experience has been as you've started to implement. There are a lot of complexities in actually setting up the screening process that we've talked about. And then I think there are also complexities and challenges around actually using that data with the individual patient. And so some of the questions that I think are important to ask and maybe probe on as you start to roll out your screening program is, who on the inpatient care team, and I'm talking from the inpatient setting to start, who on the inpatient care team has access to that screening data? Is it all of the people on the team who need it? Are they actually going to look at that information? Do they know to look for it? Is it part of their workflow to look at that and use it to drive the decisions they might make around the care plans? I would love to hear people's experiences on how that's happening. Outside of the inpatient care team, who else has access to the screening data? So I know this varies widely by organization, and there are a lot of challenges that could crop up, either related to technology barriers to exchanging information or privacy concerns. But does it make sense to share that information with other providers across the continuum? Is that possible? Are there ways to explore doing that? So, we hear both concerns about sharing information that patients may not want shared, but also on the flip side, we hear from patients sometimes, why do you keep asking me the same questions, right? Why do not all my providers on my care team in different settings have access to the same information? And so that's another thing to kind of investigate and understand who has access to the information, who maybe should or could have access. And then final question to think about is, how are you using the screening data to inform care transitions planning? So again, not only who's collecting the information and putting in the system, but what are you actually doing with it in real time? Are you able to share it with those external partners? Are you using it as you think about medication reconciliation, for example, or things like that? So I think these are just some things to kind of, as you start to implement, go out into, onto the floor and talk to providers and clinicians and say, what are you actually doing with that information? The process may seem to be going along smoothly in terms of collection, but it would be helpful to understand how that information is actually changing care. So I'm going to pause on that question and see what reactions or experiences people have with these questions as you're starting to implement. Are these questions that resonate? Are they things that you think are obvious? People are obviously using the information, or are there other challenges I haven't raised?
So Natalie, I don't think a lot of the teams are actively looking at her data yet. Are you call out Bartlett? Are you guys at this point yet? I know you're a little ahead as well.
Are we at the point of asking the questions?
Are you looking at your data yet, or you?
Oh no, we're not. We're not really pulling the data. So we're really good at getting the assessments done, especially like on our mental health unit. But we're not really looking at the data from a big picture perspective just yet. We are sharing some of that with the post-acute care partners, but I think that's more in not like the exact format that we're asking it in. And we are incorporating it into the medical record, but it would be, it's the social work case managers are entering the information, and then the coders can code from that. So,
Jeanette,
again, go ahead.
Do you think collecting this information is changing the way people provide care? Or do you think people are using the information in the screener on an individual patient basis?
I mean, I think it definitely adds to the full picture of the patient. I think that we'll have a better, I think that there'll be more impact once we start using it on the medical consistently, because I think, as was talked about by Megan, like providers will probably find out more about their patients than they realized. I think on the mental health unit, on our acute care psychiatric unit, I think which is why it's probably pretty easy to get these done, is that we've always, there's more time, there's more that you're doing with each individual patient. Like each individual patient has a dedicated social worker, case manager, a clinician, the psychiatrist, so there's more really in-depth work already being done with those patients. But I think, into some of those types of issues. So I think that once we're starting to look at that more consistently with more medical patients, that you might not think about asking some of those questions, I think that will definitely start to reveal more than what the providers know.
Mm-hmm. Anyone else have stories or experiences? Megan, the one you shared about the loneliness, I think that's a great example of how this could lead to new information. And maybe we're not there yet, but any other reactions to this question of thinking about how are we actually using the information we collect one-on-one? Okay. So it's something to think about as you're starting to ask the questions and getting those processes set up. Also make sure you're thinking about and asking, how are people actually understanding and using the information? Then the second step is, again, as we start to collect the information over time, we'll have a pretty robust source of information. In many of you probably have some understanding of the prevalence of these different social drivers of health or health-related social needs or other needs in your communities already, because there's a lot of data out there, right? There's data often at a county level or a state level, sometimes a zip code level. There's a lot of information out there about things like social drivers of health. And so sometimes I think, well, how does this help us in the aggregate, right? It could help us on an individual level, but what does this add? And what I've heard from organizations as I've worked with them is it's really personal, right? It's your patients coming into your facility. And so you can look at, say, information at a county level, but perhaps not all of those individuals are your patients. And so this just really gives you a new actionable and personal lens on the challenges that are very immediate for your patients. The other thing is it's a bit more real time, right? Some of those survey-based metrics that are more like public health surveillance or at those geographic levels, they're based on information that's always, just by design, old. And so collecting this information every day with the patients you see is going to help you identify patterns or challenges that are cropping up for your community more quickly. So as you think about how to set up systems to look at this SDOH screening data systematically, there are, I think, a couple of different steps to consider. And the first in any endeavor to look at and use data is to think about the completeness and accuracy of the data, right? Especially as you're getting set up, the data will be incomplete. It will be focused on small populations, probably particular populations. If you start in a given area, like Jeanette described, that the information is going to be skewed. And so you just want to have an awareness of the completeness or accuracy or lack thereof as the data as you're getting set up. Another piece here that I wanted to mention that we haven't really talked about yet, but it's we can't really talk about equity without talking about this, is that another element of thinking about health equity might be looking at your data by different demographic characteristics, right? Race, ethnicity, gender identity, sexual orientation, all of those things. And there's a lot of literature and examples and research too around the best way to collect that kind of information completely and accurately when we start to think about identifying disparities. So I wanted to, if you could launch a poll, actually, Debbie, I was curious in the group, what kind of demographic data are you all collecting? Because I think that's an important piece of this equity puzzle that we'll get to a little later in the conversation.
That was the second question, right? You had given me
maybe could have done them out of order.
This one?
Yeah, perfect. Okay. Perfect.
Good.
So yeah, just curious, which of these demographic categories are you collecting?
I put that they could answer more than one. Was that okay?
Yes. Yes.
Okay, good. I think if I make you a co-host, Natalie, you can see it as it's going too. I just looks like did everyone get a chance to answer? Yeah, but 8.
Yeah, this is
8 of 8. Great. So okay, let me end it now and share it.
Oh, you shared it. Okay, I got to.
Yeah, everyone should be able to see it now, right? Can everyone see it? Okay, good.
Yeah. Okay. Very helpful. So it looks like, unsurprisingly, nearly everyone is collecting race, ethnicity, and language, and then some variation on the others. Okay, helpful. More curious than anything. So I wanted to give a couple examples of how you might think about increasing data accuracy and completeness, because getting your underlying data as you look at these questions to be as complete and accurate as possible is obviously a goal, and that can be difficult to do. So I wanted to share a couple examples. This is from some work we did with hospitals in Florida, and we wanted to think about ways that they could validate the accuracy of their race and ethnicity data that they were collecting. So what we did is we looked at the percent of patients that the hospitals reported as non-white compared to what we would expect based on data in the American Communities Survey. So if those two numbers matched up exactly, the dots would be on this dotted line here going diagonally. And as you can see, there's variation that's expected, right? The percent of a population in a given zip code that's not white is going to be different from actually who shows up in the hospital, but we would expect it to be pretty similar. So what we can see with this method is that these dots over here are pretty big outliers. And so there's probably something going on here with the accuracy of their race and ethnicity collection, or it's at least worth having a conversation with them, right? If we would expect that only 15% of their population would report that they were some race other than white, but the hospital is saying 100% of patients are, there's probably something going on or something worth having a conversation about. So these are the kinds of things you can think about doing to kind of get a gut check on whether or not the data that you're collecting, whether it's demographic data or some of the social drivers of health data, is in line with what you would expect and is accurate. Another component to think about is completeness, and this particularly related to the SDOH screening. Probably over time, you want to get to screening as many patients as you can to understand their needs. And so one of the things that Debbie attached in the email she sent earlier today was a tool that we developed at Cynosure Health to help with this. So it's a pretty simple Excel file that lays out the measure specifications for the CMS SDOH screening measures. And one of the tabs in there has a graph that will auto-populate to show your screening rate over time, or that you can set up to put in your screening rate by month, for example. So this is the kind of tool you could use to set a target and then see how you perform over time. And I don't need to tell all of you this, but this is, like a classic QI method to show what are we aiming for, and then how can we look at our progress over time to try to get more complete data. And then, of course, the questions are, what can we learn from that information, that process metric of are we collecting the information? Visualizing it can help you make progress to increase the completeness. It can help you think about looking at where you see variation, for example, across different units or by different patient types. And that can help you either identify those bright spots of where things are going really well, and perhaps those folks can share out with others what they're doing. Or you might see areas that require more support or attention, right? People who might not understand why they need to ask the questions or need more resources or be having challenges for some other reason. So I think to get started, before you even start to look at patterns, you want to think about what your expectations are in terms of completeness and accuracy of your data, and then think about creative ways to work towards that and then check that accuracy and completeness. Then the second step is, of course, to actually look at the data. So aggregate the information and then analyze it and look for patterns or signals or ideas that might be popping out. Just like Megan mentioned, in terms of seeing utilities come through as a high need. So this is when we start to get to this second level of how can we use the SDOH screening data in aggregate to look at what these underlying social drivers might be in the community. And then you can start to ask questions about not only how can you address needs on an individual level, but are there opportunities for your organization, either through different policies or in partnership with others, to start to address those underlying social drivers. So I wanted to just kind of illustrate what we're talking about here in terms of how we can use data to understand a couple of different things. This is an image that shows the difference between equality and equity. You've probably seen some version of this image throughout your time in this space. But on the left-hand side, where the boxes are the same size, that represents the idea of equality, right? All of these people have an equal opportunity, shown by the equal size of the box, to reach these apples. On the right-hand side, this represents equity, right? All of these people have different levels of support to get them to the same opportunity to reach the apples. And so what we're trying to do when we look at the SDOH screening data or look at other disparities data is, how do I identify what these differences are? What disparities exist? Where are there differences between groups? Are they geographic? Are they based on race? Are there differences based on something else? And once we know what those disparities or differences are, then the important question is, what do we do about it? And how can we actually take action or build these different blocks, however they might look in real life, to actually help all people have the same chance at healthy outcomes? So we're going to talk about that idea of action in future sessions, and ideas for all the different ways that healthcare organizations, hospitals, clinics, and the like can be part of that solution and taking action with others. But I just wanted to frame that always when I'm thinking about data, it's in service of action, right? It's not just data for data's sake, but how can we use that information to understand how we can actually take steps to improve outcomes? So here's one example of how you could do that, for example, with Z-code data. So Debbie shared with me Z-code data from all the hospitals in Alaska, and I think she's going to share that with you all as well. So you could do a similar analysis as what I'm going to show. And I did use one hospital's data. It's all blinded, but it's real data. So what I did is I looked at the count of Z-codes by category. Really simple, just, created a graph to try to see where the largest areas of need are. And, a couple things clearly pop out, right? Housing and economic problems, employment and unemployment pop out. So right away, there's a signal of where you might want to focus your efforts. The next thing I did is I then broke out the housing and economic problems. So this largest bar has a number of different Z codes in there. So I broke that one out and was able to see that these are the areas that were most commonly reported. So extreme poverty, low income, and homelessness. And again, homelessness, this homelessness unspecified code really jumps out. So to me, that says, if this organization wants to invest resources in some kind of effort to address underlying social drivers of health, homelessness is a great place to start to talk with partners to understand how they can be part of the solution, because it is one of the largest areas of need based on the Z-code data. Now, you might be thinking, well, Z-code data doesn't capture everything, right? It's not even the same as your SDOH screening data, because your screening data might not always translate to Z-codes. And it's really only one piece of the puzzle, and that's absolutely true. So all of this is a lot of different signals. We have data from all different sources, and it can create a lot of noise. But what we want to do is try to find the signal in that noise, right? This is one way of thinking about, hey, we see a signal here around homelessness as a need. Does that align with what you hear in conversations with patients? Does it align with data from other organizations or other sources you see? And if the answer is yes, it gives you more support or guidance to focus on that area. Let's see, we're running out of time. So I think I'm actually going to pause on the next example. And I want to just open it up to the group. Have any of you started to think about what it would mean to analyze either your Z-code data or your SDOH screening data in aggregate to try to answer some of these questions? Or are there questions that you would want to ask of the data that we could talk about as a group and think about ways to organize some kind of analysis to get there.
The death silence, right?
Can I ask it? Oh, go ahead.
YK is still in the infancy.
What do you think would be, so what would you want to know if you could ask or answer any question? What would you hope that all this information that we're collecting would tell you to improve the way you work or your organization works? What would be your hope?
My hope would be that we could identify all the missing services that are needed, and in the ideal world, be able to bring those services here and provide them.
How about others?
One thing for Norton Sound, I think when we look at the data, is trying to make sure that our expectations of our patients are realistic. So that we're not telling them to shower 3 times a day if they don't have running water, or the way that we're giving medication or the way that we're giving home advice or whatever, making sure that that matches to the patient's actual life.
And here in the YK Delta, I think that we have identified many services that are missing. We don't have those community services available. And so we see that there is a big disconnect between services needed and services available. And so it's coming up with ways to form partnerships and get some of these other services that are usually offered by community groups outside of the corporation.
This is Kristen Fairbanks, and I would have to agree, with Megan. I think those things that are beyond our control for the first year or two until all of the numbers get in and get reported and funding becomes available, I think are really important for the human understanding piece, that patient experience piece, and just really understanding where our patients are, what their needs are. If we can discharge them right away and they don't have running water, and that's okay for that particular diagnosis, or do we need to hold them until we can locate another place to discharge someone until they have the services available to be safe and not be that readmission? I'm looking forward to see if it affects our readmission rates too, to be totally honest. But just understanding people and meeting them where they are and providing them with that extra level of connection and mindfulness in the moment as we're having every care conversation with them, because we're understanding not just, okay, this is a cholecystitis patient, 57 years old, male, and he lives home alone and he has dementia that comes and goes. It's actually understanding, this is my neighbor John, and he's retired. He used to be a railroad worker. He does have some things available, but not a huge community support group. He prefers to be alone and live alone. So if we try to put him in a situation where he's forced to be interacting with tons of other humans, it might cause frustration for him, and he might become less compliant. So just little, that's a terrible example, but just the little things that make patient care successful.
Chris, do you think how naturally do you think it will happen that rolling out this screening will promote exactly what you're describing? Do you think there will be challenges or barriers?
I think the biggest barrier is who is doing the screening and who has it right there in front of them. And is this incorporated into nurses and bedside caregivers doing the screening, or registration people doing the screening? And then once that screening is done, is it incorporated into the IDTRs, which is the interdisciplinary team rounds? Is it communicated as, are we growing a culture where we talk differently about our patients and that human understanding, and really our whole patient, not just why we have them here? It will be interesting. I am, of course, hoping for the best, but it'll be interesting to see if this gets lost in the weeds. I really hope it doesn't, because it can be so valuable and powerful. It'll be interesting.
Yeah, those are all great examples. I mean, I would be very curious to hear if and how it gets incorporated into those interdisciplinary team meetings and what your experience is as it rolls out. So we will stay tuned. But I think that's, you know, exactly the questions of how do we use it on an individual patient basis, even if only the person doing the screening understands their role and can do that in a really a way that engenders trust and is very supportive. What if the information doesn't get to all the other providers who see the patient, right? All the other people on the care team. I think it's a lost opportunity. So figuring out how we actually use the information across care settings, I think will be a big challenge, to say nothing about actually collecting it. So thanks for sharing that.
Absolutely.
Any other thoughts or early ideas about how you might look at your data or use it in aggregate? Megan, you had a point on your slides about grants. I'm curious if you'd use it in grant proposals or anything like that too, or if others have thought about that, how to take this information out and say, look, we have these needs in our community. How can we partner?
I will say we already have used it in a few grants. So being able to provide some data is very helpful when we're discussing needs, and being able to say, look, we can kind of prove it as far as needs. We've had to, for HRSA for years, stratify things like our diabetes rates and our hypertension rates by race and ethnicity. And as a primarily tribal hospital, one of the things we noticed for years is that our diabetic rates were better among our beneficiaries than our non-beneficiaries, which is counter to the national trend. But we realized that some of our services were only available to our beneficiaries, and that was a limiting factor. We weren't taking as good of care of our non-bens. And I think that's something, you know, we focus on, and then trying to work with those folks and figure out, okay, what are your limitations? Is it cost? Is it transportation? What is it that we're missing in getting to you? And then I think one example that we used in our data recently was there's a question in the survey about access to community parks and safe places for outdoor activity. And based on our response, that a lot of people said, no, they didn't have that. You think of Alaska Native villages and places like Nome, we have plenty of outdoor space, but we don't necessarily have walking paths and things like that. So our board used that data recently with some funding we have to, we're building outdoor basketball courts in our communities and using some funding, and we can justify that through this data.
That's great. Great examples.
Bettina put something in the chat. She may not be able to talk, but she's from Haines, and she put, my hope would be that we would be able to bring realistic expectations to the community in Haines: transportation needs, access to healthcare, what is available, and what we can do to bring services. I think that hits the nail on the head.
Has anybody thought about how you might use the information to partner with others, or bringing this information externally? I think, you know, oftentimes if there are resources available, it's kind of clear how to connect people, right? But if there aren't, it's a bigger question about what is the hospital's role? How can you bring this information to any number of other people? Do you anticipate challenges with sharing the information, or is that something you think would be useful, or how would you even think about doing that? Does it fall within your scope of work, or is that something someone else in the organization would take the lead on in terms of this broader community conversation about needs?
This is Jeanette. This is hard because I don't have like the data or like so the specifics to say what it would be, but for a long time we've talked about and have talked with public health about when we can get some of that, you know, higher level data, how we might partner with public health to perhaps address some of the gaps that we're seeing, but again, I don't have the specific data to like give examples, but that's something that's on our, you know, big picture wish list or our big picture kind of plan down the road when we have more to go with.
Yeah, that's helpful. So even just starting the conversations about partnership before you know where to focus, but undoubtedly there will be things to focus on. All right. Well, I know we're going to transition to Jesse in a few minutes. So thank you for starting the conversation and thinking about how to use the information. I know it's complex, both at an individual level and then an aggregate level. So appreciate the opportunity to think about some different options. Usually we have kind of light homework assignments between sessions. So my suggestion for the next one would be to either figure out if you can pull some kind of data. It could be anything. It could be like, can I get access to screening data out of my EHR? Or can I look at the Z code data? Or is there any way you could start to think about pulling some data that would inform your implementation? And then coming back next time, we can reflect as a group, like what challenges did you run into? Did you learn anything? Just to start to think about that challenge of using the information to inform implementation and action, because I think there's a lot of complexities that come up. So that was it for the data introduction today. Debbie, I will turn it back to you then, I think, to introduce Jessie and look forward to hearing from her.
Yeah, and I wanted to, and Kristen mentioned in the chat, we'll send out your Z code data by the end of the week. So you'll have that. So if you want to look at that for the next meeting with Natalie, and we haven't set that date yet, but looking at probably November or early December for that next one. So we'll get that invite out by probably by Monday. So for those of you that can't stay on, feel free to just give me a wave or head off or sign off. That is totally fine, but we're really excited to have Jessie talk a little bit about her e-referral project with SDOH. And so she's gonna do that for about a half hour, has some slides. So if you can stay on, that's great. Thanks, Jessie.
Yeah, thank you. Let me hit share quick. Okay, you seeing the right slide and everything?
Let's see, it says you're
Not quite yet.
It hasn't popped up yet for me. Let's see.
Oh, my system sometimes gets grumpy with me on Zoom and it will freeze. If it freezes, I'm gonna log right back on and I might need one of you to share. Sorry.
I think you're frozen right now.
What was that? You wanna put stop sharing, try it one more time.
Okay, let's see. I haven't plugged in my Zoom. I apologize, guys.
No worry, I'm gonna go to your find your slides too, because I didn't open them, and that way I'll have them.
Gives everyone a mental break between presentations.
I think I need more than just a break for my mental health. Can we do so maybe some sort of actual intervention inside here?
Here we go. Okay, you got them. Oh, okay, good. I was just getting them ready, but it looks like you got them.
Well, we'll see. If it kicks me off, we'll try it again. I'm so sorry. I did a meeting yesterday on Zoom and it didn't freeze, and I said, oh, maybe I have extra demons, but maybe
no
not.
worries. I have them ready if they do freeze.
Perfect. Okay, but you're seeing the right screen and everything?
Yep, we see your title slide.
Okay, perfect. So my name is Jessie Downs. I'm a nurse consultant with the state of Alaska. I work in chronic disease prevention and health promotion. And I am here to chat with you guys today about a multi-directional e-referral pilot that we've been doing a little bit over a year into the project now, and just sort of share what's been happening, talk about if it's possible to expand, and if there's options or lessons we can sort of share out together as we all work towards SDOH screening. I do want to start with a land acknowledgement. I'm here in Anchorage, live in Eagle River, both of which are Dena'ina Athabascan lands. I just want to recognize my thankfulness for the generations of stewardship of this land and my sincere hope that my work creates systems and opportunities for all people to thrive on these lands. And like I said, I work in chronic disease prevention and health promotion under the Department of Public Health, the Division of Public Health and the Department of Health. And this is just a real quick graph of where I sit because I know the state system is confusing. All right, so I wanted to start really fast. The slides I'm showing you today are kind of a canned set that I've used in a couple different presentations. So if what I'm sharing isn't helpful or if you have any questions, let me know. I want to be a good resource for you guys. But I like to start with the story of Frank. Frank is obviously not his real name, but he's an elder and he lives in the Upper Sioux area of the Mat-Su Valley. He's on the road system, but he's far, far away from any of the urban settings in Alaska. He had a recent change in his health and he needs a wheelchair, but he's unable to get one because they're having a difficult time finding a DME distributor in the Upper Sioux to get him a wheelchair. And the out-of-pocket cost is too much for him. He has been waiting, working with his provider. His provider's filled all the forms. Everything's been done. It's not a matter of his care team not working at their highest level. He's just waiting. And while he waits, he's been using a child-sized wheelchair that his neighbor could give him. Obviously, the wheelchair is way too small. Frank doesn't fit in the wheelchair well. He mostly just uses it to get bed to bathroom, bathroom to bed. He doesn't leave his house very often. And like I said, his care team is doing their best, but they have the limitations that all of you guys are completely familiar with. Just been struggling to figure a solution out to make it happen. The resources at his clinic aren't sufficient enough to, put the time and energy in to fix it. Frank's health literacy isn't high enough for him to spend 6 hours a day on the phone trying to find a solution. And so we're kind of stuck in this spot. Frank has an appointment to see his primary care provider, and before he gets to his appointment, he's sent the prepare form and fills it out on his phone before he gets in. Goes in to see his doctor for something completely unrelated to his wheelchair needs. And the next thing he knows, he receives a call from Connect Mat-Su, who was notified that he had a health concern. And they make a few phone calls and find Frank an appropriate adult-sized wheelchair. And he has it for as long as he needs it. So the moral of the story is, again, you guys know this, you're working in healthcare. Everybody on his team was working to their highest level, but no single agent had all the tools and resources necessary to meet his complex care needs. But because his clinic was participating in this newly implemented social determinants of health e-referral system, Frank's primary care provider's office was able to meet Frank's needs with a referral to a social service specialist without any additional work on the end of the provider or the care team. So this SDOH e-referral system is really designed to link services together for a whole person access using technology without creating extra work on the providing teams. Very high level, you guys know what SDOHs are. They're really the things around where you're born, raised, live, worship that impact your health outcomes. And HP 2030 has a great quote saying that just telling your patient to make the healthy choice isn't enough to move the dial in their health, in their social determinants of health, that it takes a whole person approach to addressing the needs both inside and outside of your care setting. So a really high level snapshot of the project. It is located at Sunshine Community Health Center, which has 2 FQHCs in the Upper Sioux region. They just closed the one they had in Wasilla. They have one in Talkeetna and one in Willow, and they have 7 school-based health clinics, and they're based in the Upper Valley. Like I said, the project participants were the State of Alaska Section of Chronic Disease Prevention, Sunshine Community Health Center, Connect Mat-Su, which is part of the Mat-Su Health Foundation, and then Telask Technologies Incorporated. It took us a little bit over a year to get to launch date, but our launch date, our official go live was 5/1 of 2023. And because we were able to use Connect Mat-Su, which I know is a unique resource that's not available across the whole state, but because we were able to use them, we were able to link together hundreds of state, local, and federal social service resources And we were able to incorporate in the Alaska Tobacco Quit line into this project. And it's currently funded in its pilot phase by the state of Alaska using some social determinants of health funds under our COVID grant. But that funding is reaching its end. We're coming to the end of the pilot phase and we're looking to move this out into something sustainable and expandable across the state. And the data platforms that we integrated was the Athena EMR, the Salesforce system, which Connect Matsu uses. TELASK has a program called the Quit Manager, and the Alaska Tobacco Quit line. We're all integrated in this project. This is absolutely unreadable to anybody on this presentation, and I apologize, but this is a very high level look at the project and the partners. What you can see here in the gray is our second phase, is that we're really looking to integrate a tertiary care facility, a hospital, an inpatient facility, something to that tune into this project so that we're able to not just link the primary care needs, but to link primary care and hospitals together as well. So a very high level overview of how this bidirectional e-referral concept works. Basically, the social determinant screening excuse me, assessment is done. And as I said, the Sunshine Clinic chose to use the prepare form also for many of the same reasons that Megan mentioned. We are then connecting individuals to customized services and closing the communication loop. So Sunshine providers know what happened with the social service needs of their patient. That loop is closed back with the providers. Also using that data to track outcomes and track needs, again, closing the loop back with the patient and with the provider. And then using the data, as Megan and Natalie both mentioned, to sort of create community-focused needs interventions based on gaps that we're identifying from the data that we're collecting. And all of this is kind of under the overall plan, which to leverage data to address social needs, address social needs to meet health needs. So what each partner does, Sunshine Community Health Center completes the prepare form as they do it when they're a new patient and then once annually thereafter. They use a third-party vendor called Evian, who sends it out to people in a link in an email that they can click on, fill it out on their phone at home, or if they get to the office and they haven't done it, it pops up on a tablet and the patient can fill it out themselves at their pace before they're taken back for their intake appointment. The information is immediately ingested into the EMR, and currently we're doing something called opt-in, which means even if needs are identified, the patient themselves has to say, yes, I want my information sent to Connect Matsu to be addressed, which is different from an opt-out model that we're doing in the tobacco screening. So everybody is screened for their SDOH information. It's uploaded into the EMR. If the patient opts in, it's then sent over to Connect Matsu, which we'll talk through in a little bit. During the intake process, all patients are screened for tobacco use, including vaping, smokeless tobacco, ICMIC, all the above. And then tobacco patients are all sent into the Quit Manager. This is an opt-out system. Every patient who's identified as smoking is sent into the Quit Manager, and I'll kind of talk through the Quit Manager process in a minute. Sunshine has patient navigators that they work with who sit down with patients who have not checked the yes, I want to be seen button to kind of help them understand the value of the project and the importance of it. And they've done a really good job of converting a lot of those opt-outs into opt-ins to help get people connected into the Sunshine or the Connect Matsu programs. Patient data is then sent directly to Connect Matsu through a secure SFTP transfer. It's sent over daily. So everybody who opts in to having their information sent to Connect Matsu is sent over. And then patients are ingested into the Connect Matsu Salesforce system, and then they're contacted by a Connect Matsu specialist. They're offered services not only for their identified SDOH needs, but anything else that might come up during the course of their phone call with the patient. Patient outcomes data is then collected, aggregated, and sent back to Sunshine Health Center. It's sent back in an aggregate to their quality program, who can then look at kind of their types of needs that were addressed and the numbers, but it's also sent back as a closed note into the patient's chart rather, so that if their provider is interested in what happened on each individual patient level, they can then go into the closed note and find it in there. And then, as I said, Connect Matsu and the Matsu Health Foundation, as well as Sunshine, are using the data to identify gaps in the services available to their community. And in the future as we kind of get more trends, work with community agencies to fill those gaps. All right, so the Quit Manager is a service within the TelAsk Technologies solution. Basically, the Quit Manager works with patients as they navigate through the pre-contemplative and contemplative phase to decide that they're ready to quit. The Quit Manager, like I said, is owned by TelAsk themselves. Patients are contacted. It's completely customizable how your patients are contacted, what frequency they're contacted at, and it's designed to be invisible. The phone number used to reach out to your patients is the phone number from Sunshine Community Health Center. The patients are contacted using voice messaging, text messaging, phone calls, whatever works. They kind of walk through a workflow where they're screened and encouraged to quit, identified for readiness to quit. And once patients identify that they're ready to quit, they're then referred over to the Alaska Tobacco Quit Line. And patients who are not yet ready to quit but do wish to be contacted back later are kept in a queue and they're contacted back on a regular basis. As I said, the Quit Manager is completely invisible, so patients feel like they're being seen by their healthcare provider and not by some outside agency that got their number from somewhere, right? Really quick, just review of the quit level process. In the first swim lane, we're just identifying they're the right person. Can we talk to you now? Maybe later, hang up, reschedule, what have you. In the second swim lane, once we've confirmed who they are, we confirm their tobacco use. Have they tried to quit or they're interested in quitting? And then they're sent over to triage or they're counseled through. Quitting is the most important thing you can do. For your health, we have services and resources that we can help connect you with. Are you interested in being referred now? And if so, they're sent over. Would you like to be referred later? And then they're put into a track. So how is the project doing? Unfortunately, I'm still waiting for the third quarter data. I just got half of it earlier this week. So I'll show you our data from May through June. As I said, the project just kicked off 5/1. But you can see 106 total patients were referred for SDOH needs. These are 106 patients who would have been screened, but otherwise would have had no referral offered to them because Sunshine doesn't have the tools and resources to make these social connections. And then you can kind of see how they're split out with looks like the biggest need being health, things like wheelchairs, specialist appointments, things like that. Second one being housing and then transportation. In that same period of time, 29 folks were referred to the Alaska Tobacco Quit Line. What I love about this data is that it's 29 people who were ready to quit, not 29 total people, right? You can see 806 smokers were identified when they removed all the redundant appointments and all the people who were, visiting Talkeetna for the summer and sprained their ankle or what have you. They were left with 186 unique and appropriate patients. Of those, 124 are still in that tracker, and 14 were sent over to the quit line to make a quit attempt. That's really awesome data. Those are people who would have been screened for tobacco use, maybe given a card for the quit line and sent on their way. But this active patient connection converted 29 people into making an actual quit attempt. And it looks like nearly 200 people are staying in the queue to be called back in a couple months to see if they're ready to quit. I love it. It's such awesome data. So really quick high-level overview of our process. We did our development and implementation, which we're currently in the process for, and we're really starting to look towards widespread adoption and sustainability. The funds that we're funding this pilot under will be coming to an end pretty soon, and we're looking to move this out into a way that can reach more Alaskans across the state with our proven model of success, but in a way that's sustainable and not dependent on grant funds, which I'm sure you guys all know come and go. This project is we're trying to really fit it into lots of different work that's going on around SDOH screenings and referrals with the work of this group. There's also some work with the Health Information Exchange, who's working to create a Z-code dashboard for us. The AZARA and the HIE are looking to integrate to like single standardize how access to data, again, linking back to that dashboard. The Quit Line is working to expand their statewide reach, and we are trying to do a community information exchange integration in our dementia program, which will be a program that will link community agencies into a community-based HIE, if you will. So we're trying to build all these pieces. They're running at separate speeds and separate paces, but in the end, we want them to all meet at the same finish line. So this project is trying to integrate into that bigger picture of what we're working on. We want to make sure that we're balancing multiple technologies and projects without creating redundancies, or putting a lot of work and effort into one system that then becomes obsolete when the other system starts up, right? So running these projects in tangent. So next steps, how can partnership and collaboration move this project forward? Do you guys have any questions about the project or sustainability? Really, how are we going to reach all the Franks in Alaska to make this connection for services? That is the end for me. Did I miss any questions in the chat?
Yeah, Jeanette had one. She wrote, what are your thoughts about long-term funding?
Yeah, that is my continual thoughts day and night about long-term funding. We're looking to hopefully find some entity with either a statewide reach that's interested in picking up this project, or identifying if there's a way that the state could maybe maintain a central ownership of this process, but of this project, but then work with smaller direct one-on-ones with hospitals or FQHCs in the state. We're really sort of open to the conversation. What does it look like?
Can you maybe share what it would share what it would look like in a hospital setting? It's very clear with the clinic, and it's hard for me to think about like how this would work in an inpatient. Or I know you guys were starting to work with an ER initially, but that didn't work out.
Yeah, we did originally try to work with an ER, and actually our biggest barrier with that ER wasn't how to do the screening, it was how to get their corporate big cheeses who were downstates to approve us making changes to a standard of it. They have a very standard process that doesn't allow for a lot of change, which is why we then switched to a local organization that had a little bit more control. But I think that it would look a little different probably in a clinical setting. Likely the prepare form would be completed in the pre-admission paperwork or in the admission paperwork. The big piece to the success is Connect Mat-Su, right? And Connect Mat-Su doesn't exist everywhere. But what we've been working with is the possibility of linking the SDOH screening to another agency like a community health worker organization, or like social workers, or the borough, or any other entity in your town or area that's doing kind of the social work screening, triaging, and referrals. So it doesn't have to, and the neat thing about this project too is that it's really customizable to your community. So let's say you have this organization handles food, this organization handles transportation, this one handles domestic violence, what have you. The TelAsk platform can be sufficiently customizable that this Z code goes here, this Z code goes here, this Z code goes here, and you can actually, it doesn't have to be an entity like Connect Mat-Su. Though gosh, wouldn't we love to replicate that success in the whole state? Like, that's a great program.
So Kate actually asked how Connect Mat-Su was funded and organized.
Connect Mat-Su is under the Mat-Su Health Foundation. I think it started under Rasmussen's greenhouse project, or whatever they call that, incubator nursery. There's a name for it, but it started there and then was transferred over the Health Foundation. And then the Health Foundation is very uniquely funded using some tax dollars and some revenue from the hospital. And it could potentially be part of an 1115. There's a 1115 for health-related social needs that's being worked on right now. But it's going to be population specific. It won't be for any and everybody, but yeah, potentially referrals to SDOHs should, or health-related social needs, insert your acronym here, but it should hopefully in the future be able to be covered, at least in part, by some populations through the 1115 process.
Yeah, like I wondered if you could bill enough for the certain covered populations that maybe you could end up covering everybody.
I mean, maybe. You know, there is some work we put forward. Well, my supervisor put forward a suggestion for kind of bigger population bumps to include in this waiver. If that's selected, then that might work. If it's a smaller population that's picked for the waiver, it might not. But yeah, very possibly.
I thought there were some interesting things that in the project that could benefit people, even if they're not doing it to this level, was that they used a vendor to send out the form, the screening, and that automatically, that data shuttle put it into their EHR at the clinic. So that's a need that I see people that are having. I tried to reach out, but didn't get any answer on how that works. But I'll keep working on that. When I get that information, I'll share it with the group. And then that automatic referral piece on the end. So it's got two different vendors, two different data shuttles, but an interesting way of doing that.
Yeah, we definitely did it wrong more times than we did it right. Like there was a lot of, whoops, we got to fix that. We send a bunch of underage kids over to Sunshine to Connect Matsu the first time. And they called a 15-year-old and we're like, oh, hey, do you have a housing issue? Because we didn't include age in the data we sent over. And we had to fix that real quick. And there was the outcomes data started coming in duplicates and doctors were getting 6 or 7 outcomes per patient. And that was logging up their inbox. Like there was a lot of work for sure. It's taken a long time and we're just doing a lot of cleaning up, dusting and cleaning and fixing the process to get it streamlined. And that was after, almost a year of planning. Then once it went live, there was still lots of areas for fixing. So
cool. Does anyone have any other specific questions for Jessie? So if you're thinking about implementing or wanting to do this in your community or your facility, just reach out to Jessie for more info, or Debbie and I, we can get you the contact if you need it. And like I said, I'll keep working on that vendor info on the data shuttle, because I know that piece is a need that some of our facilities have been asking about. Well, cool. If no one has any other questions, then I think we'll be done a few minutes early. Thank you, Jessie, for coming on, and Natalie for coming, and Megan for presenting earlier, and everyone for participating. Like Debbie said, we'll do a meeting probably early December-ish, end of November-ish, not sure exactly when. But we'll send that invite out soon after we've had a chance to chat with Natalie. And if you have anything else you need, just reach out to us. Thank you.
thanks everyone.
Thanks everyone. Thanks for staying on for so long. You all have a good afternoon.
Thanks.